Hello, everyone. Welcome to our top tips in medical and surgical management of BPO. We were hoping to do this talk and a much larger version of this talk in Amsterdam, but we have kind of transited to doing top tips in medical and surgical management of BPO. And we were going to meet in Amsterdam for a bigger lecture, but now we're going to make the lectures smaller. And the title is Top Tips in Medical and Surgical Management of BPO. All talks are for 15 minutes, followed by 5 minutes for questions through the portal. And this is accredited when you complete the questionnaire after attending this webinar. So I'm going to start off by a 15-minute talk on is BPO a progressive disease, clinical aspects for best outcomes. Then you have two world-renowned experts, Thomas Herrmann and Sascha Ahyai. We're going to talk about best practice guidelines in 2020 for electrosurgery and steam therapy. And the next lecture, of course, from Sascha is going to be best practice guidelines in 2020 for lasers and less invasive treatments. So we're going to move on now. I have no conflicts of interest to declare. It's very important to focus on a patient-centered management program. Main concern for a patient with BPO LUTS is worsening of the symptoms, risk of surgery, and risk of urinary retention. So is BPO a progressive disease? Well, there's a lot of evidence, and broadly you can divide the evidence on community-based studies or the placebo arm of clinical trials. These studies, the community-based studies, are listed on this slide, and you have the mTOPS plus reduce ALF1 ALTEST studies, etc., that have contributed significantly to understanding the natural history of benign prostatic obstruction. The factors that progress are very important when the patient is sitting across you in the outpatient clinic. The patient wants to know whether they have a problem that can get worse. And when you counsel this patient, you want to think about looking at the following factors: symptoms and the bother they get, what is the flow rate, the prostate size, PSA. Try and estimate the risk of urinary retention. I'll kind of give you one or two pointers for that. There's lots more in literature you can look at. What is the effect of residual urine volume or inflammation? Obviously, age is a very important factor here. So our index patient is going to be a 73-year-old with a PSA of 5.6 who complains of a slowish stream. He has about a 40 grams in size benign feeling prostate. He's got a high BMI and he's on statins. The biopsy shows benign prostatic tissue with some inflammation. His IPSS suggests moderate lower urinary tract symptoms, 14 out of 35 with a quality of life 3. His Qmax is 12 mils per second. I've highlighted the areas I'm going to discuss in yellow as it's clear there. His post-void residue is 60 mils, okay? So if we move on, his first question to you is, okay, doc, you say I got moderate symptoms. How likely is it that I can get worse? So if you look at the data out there, if you have patients on a watchful waiting program and you follow them up for 5 years, you find that 64% of these patients are doing well in this program. 36% have crossed over to surgery, and the key predictors here were increasing bother and post-void residue. Men that were less bothered, i.e., they had milder symptoms or their bother scores were low, the treatment failure over 5 years is even lower at 21%. So the next question your patient's going to ask you is, okay, you tell me, doc, my flow is slow. How likely is it to deteriorate further? So you got the Olmsted County studies. They looked at 2,000 men and followed them up for 6 years. The ages were between about 50 and 70, and they looked at the peak flow rates. There was a median decline in the flow rate of about 2% per year. What is more important in this and other community studies were that the two biggest predictors of a more rapid decline was a baseline Qmax of less than 10 mils per second, which is fairly slow, or an age more than 70 years. So again, these are the points you kind of want to think about when you're counseling your patient. So your patient then asks you, okay, doc, you say my prostate's 40 grams in size. I don't know how large your prostate is, but will my prostate continue to grow or increase in size? And you kind of quote the studies that are out there. You have the placebo-controlled trials, which is the MTOPS and the REDUCE trial, and then the alpha blocker arms of the MTOPS trial and the COMBAT trial. And all these 4 trials show that the 4-year change from the baseline is an 18% increase in the prostate volume. There are other studies that are community-based, the Dutch Krimpen study, which measured the prostate volume. You had a Lieber's study again, which looked at the volume at baseline. They all suggest that there is an increase in the prostate volume. And this figure at 4 years is a figure that you kind of need in your head when you counsel your patients regarding the change in prostate volume. The next question is, my PSA is slightly high. You tell me you've done a biopsy. I don't have cancer. So what is the relevance of this reading? Why are you checking my PSA? So obviously one of the reasons you check the PSA is to monitor the readings, but the important point for us to understand for the purpose of BPO progression is that PSA is a strong predictor of prostate growth. It is a stronger predictor of prostate growth than prostate volume itself. And you can see on the right side, if your PSA at baseline is more than 3.3, then the annual increase in mils in your prostate size is more than 3. PSA is also a predictor of changes in the symptom score, quality of life stroke bother, or in the maximum flow rate. And the guidelines suggest that you measure the PSA if it assists in the treatment or the decision-making process, and it's classed as a strong evidence. So the next question your patient wants to know really is, doc, what is the risk of my acute urinary retention? I'm terrified of this problem. I'm absolutely terrified. I cannot put up with symptoms. Will I block off? So you kind of say, okay, so what data can I look at here to counsel my patient? So one of the things you can think of is the PLES trial. And you had 3,000 men in this trial, and they looked at patients with an AUA symptom score greater than 7 over a 4-year period. And as you know, this was a placebo-controlled trial against finasteride. And the risk of acute urinary retention in this trial in about 1,500 men was 6.6, where there was no intervention, and 2.8% if there was acute urinary retention. So kind of, is there any other evidence you could use in your counseling? Yes, of course. You got a lot of natural history studies. A lot of these studies are unlikely, in my opinion, to be repeated. So they're very relevant. And as you can see from this, you have various criteria. What's the baseline prostate volume? What's your baseline Qmax as opposed to someone who's got a Qmax more than 12 mils per second? And therefore, what is their risk of urinary retention? And if you look at this arrow, you can see age greater than 70 perhaps is the most relevant cause for urinary retention, apart from moderate to severe symptoms, which again carries a 4 times higher risk. So that's another point you want to keep in mind. Were there any multi-center placebo-controlled trials? Yes, there were a large number of these trials in the late 90s and early 2000s. I've given you the list of trials on the right side: Prospect, Prowess, SCARP, and PLUS. And all these suggested that, although it sounds pretty low, don't forget these were large randomized trials. The PSA readings are not the ones that you see in the outpatient clinic. But all these trials suggested that your PSA greater than or equal to 1.4 was a sensitive marker for increased risk, as was a prostate volume of more than 40 mils. So he wants to particularly know his PSA is 5.6. So you have a really excellent paper, which I kind of show you here, where you can estimate the risk of urinary retention, and you could use this as a criteria. There are other papers that estimate the risk at around 12% for a PSA between 5.5 and about 10, and this gentleman's risk of urinary retention over 4 years is 12%. So that's another point you can kind of get into your discussions. So baseline PSA can predict the risk of acute urinary retention and BP, benign prostatic enlargement related surgery. So that's the other important point for you. So I kind of got 3 minutes remaining in my presentation, so I kind of move on to the next one. So Doc, you said at the start that I have 60 mils of urine remaining behind in my bladder. Is that important? Well, yes, and these are the points you kind of want to think about. Incomplete bladder emptying has many causes. It could be detrusor underactivity, not necessarily bladder outflow obstruction. What is important in post-void residue is to monitor changes over time, and that is really an important thing. It's a large residue is not a contraindication to watchful waiting or conservative management or medical therapy, but it might indicate a poor response to treatment. So the MTOPS and the ALTLES study said a higher post-void residue, as shown in the graph, although they picked out a figure of about 39 mils, which kind of sounds small, but that was the data, increased the risk of symptom progression. So measurement of post-void residue, perhaps the change in the post-void residue is really more important criteria. So the next point, the patient says, the doctor said I got inflammation in my biopsy. Should I be worried? Is this kind of going to cause problems? So again, inflammation can be linked to the metabolic syndrome, where you got hyperlipidemia, diabetes, obesity, steps on statins, hypercholesterolemia is one of them. And the reduced trial clearly showed that chronic inflammation, as you can see on the graph on the red, my arrow indicates to that, was associated with an increase in prostate volume over a period of 4 years. Also, there was a higher risk of acute urinary retention, perhaps seen in patients with more severe chronic inflammation. The next point really is physician-diagnosed prostatitis has a higher risk of needing medical or surgical treatment, but this could be biased because you're more likely to look at your patient and offer them more interventions because of the prostatitis. So that's another important thing you've got to keep in mind. So in summary, BPH is a progressive disease. The factors that progress, change, or get worse, and that you need to take note of when you're counseling your patient regarding the treatment options are symptoms of bother, flow rate, prostate size, which includes the prostate growth rate or the baseline prostate volume, the baseline PSA reading, and obviously your patient wants to know the risk of urinary retention, what is the relevance of a post-void residue, or of inflammation seen in your biopsies. Now, this is very important because this is one of the drivers of your treatment, progression, reducing the risk of complications. If you put that into your funnel, then you kind of think about the medical therapies or whether you want to manage your patient with watchful waiting and reassurance or conservative measures. So that's my last slide, and I'm going to end here. Before Professor Herrmann gets on with a fantastic lecture, I'm going to open the session for questions for a few minutes, 4 or 5 minutes, so we can keep the program rolling. Thank you.
So, Vijay, can you hear me?
Yes, thank you, Sascha. I can hear you now.
Okay, perfectly. There are some questions from the audience. The first question is from Sudhir, he asked, will my symptoms improve after TURP, and what symptoms will improve and which will not? Can you answer
So
this question, although it's a surgical?
yes, it is. It is fantastic. Thank you for that. So it really depends on what your baseline symptoms were prior to your surgery. That's really, really important to counsel your patient. So if you have a patient who's got predominant symptoms of detrusor overactivity, it is very important you counsel them that the first thing that will improve is your flow. So you'll notice your stream is going to get stronger, and I'm going to lessen your risk of urinary retention. But we know from Paul Abrams' data when he looked at these patients on behalf of the ICS studies that your irritative symptoms may not get better in 20 to 30% of patients. And if it does get better in the remaining 70 to 80%, it may take some time to improve. So you got to look at what your symptoms were before you went into the operation.
Okay, thank you very much. There are some more questions, like 5. So maybe if you give a quick answer to all of them would be perfect. Next question, is there a point of time during the disease progression at which TURP should be recommended to avoid further damage of the detrusor muscle? For example, underactive bladder or hypocontractile detrusor probably.
Yes, I mean, I think if you, that's a super question. Briefly, monitoring for change, monitoring for worsening of the border score, worsening of the IPS, increase in the post-void residue. We discussed those issues. Increasingly, we find that the PSA is an indicator for worsening symptom score and border. So you look at all this, and when you monitor for change and you show a deterioration, it's time to intervene, particularly on conservative management.
Okay, what's the upper limit of post-voiding residual urine you accept without catheter?
There is no limit set according to various papers on the post-void residue. What we do know about post-void residue on the MTOPS and ALTES study I've presented, but generally, if you look at a post-void residue cutoff of 50 mils, and I'm trying to be brief on this very extensive topic, your positive predictive value of benign prostatic obstruction is about 60%. Okay, so by itself, it's not a criteria, but a change in post-void residue over a period of time is more important.
Okay. Then final question, should we consider a 30 milliliter prostate volume as a risk factor for progression, or is it 39 milliliters? Because of AUA guidelines consider the 39 value as cutoff point.
Sascha, can I clarify? Did you say prostate volume?
Yeah, I said prostate volume. Should we consider 30 milliliter prostate volume
Yes,
as a risk
I mean,
factor?
the guide,
39 milliliters.
But the guidelines will always vary, and once again, the larger prostates can be associated with a higher symptom score. But whether you kind of use a baseline of 30 to 39 milliliters, very important to know how you've calculated that volume as well. Is your truss? Is there a median lobe? What is the nature of the symptoms? So just one cutoff thing is not only the most important thing. You want to link it up to the PSA reading, but I think we're going to stick with the EAU guidelines of a baseline volume of 30 mils, where a lot of the data is based on.
Okay. Shall I tease you and ask you how big your prostate is when you come?
Yeah, it's a fantastic question. I do know because of various reasons that it's moderate in size, and I don't want to elaborate further. Thank you.
Thank you. Very good answers. Very good presentation. Let's give over to Thomas.
Hello. Yeah, thank you very much for the introduction. I'd like to straight start with my talk. It's about best practice guidelines in 2020 for electrosurgery and RESUM. This is my only potential conflict of interest in the moment. I would like to start, we are talking about bipolar technology or high frequency surgery technology. we have to talk about the template. And I always like to start with that because we have to distinguish between gradual treatments or binary treatment. Binary means you have done it or not, and it's a distinguishing between extra anatomic and anatomical. Or if we looked at the PSA drop, or the PSA post-operative drops by 80% if you do an enucleation, and it gradually reduces depending on your skill set or how you interpret ablation when you do extra anatomical technique, and it doesn't change anything if you use mechanical devices. So that's very important. So the question is, do we have to continue do TURPing or not further on? And first of all, we'd like to look where is the stand for TURP at the moment. Again, the EU guidelines, you see here, there's a lot of TURP you can do in the first, the second, and the third column. And the only reason why it's not there in the fourth column for patients on anticoagulation is because the data is not so mature to have it on the same level as the others. So that is basically what we are talking about, size-dependent treatment. And the question is TURP really a gold standard? As you can see here, peeling the apple from inside. You have the data from UK here, and it's about roughly 40% reduction. So not 60 or 50 in the UK, it's 40. Because the problem is that TURP is not a real gold standard because it's not convertible, because there's no agreement on the template. The same accounts for vaporization. If we look, for example, on the Goliath study, it was a European, more or less dominated study. We had a PSA reduction of 58%. And if you look into the TURP arm of the aquablation study, it was only 25%. We have all data from from the KTP, it was also around 25%. So there's a huge difference. So TURP, not only as a comparator, is not equivalent. So the reason for that is you can buy sling, but you cannot buy TURP. That is very important. The only place where you can buy TURP is if you go to places where there is the talk language, there you can buy TURP. However, the reason for that is that TURP is an inside-out technique, and during the surgery, there's no obvious anatomical layer reached. The same accounts for vaporization. As said, it's extra anatomical. You see thermocoagulatoric alteration of the level of resection. You have two problems mainly. If there are problems, you have the too little issue with incomplete resection and residual adenoma probably that will recur. And on the other hand, if you are too ambitious, you have the too much issue, you can damage the peripheral zone and damage the surrounding tissue, neurovascular bundle, sphincter, and you can do you open a sinus if you crash ventrally, you have bedside, long operation, hyperhydration in bipolar, or TUR syndrome in monopolar, and you can go for acidosis, which nobody really considers in bipolar if you put in too much. How much morbidity do we see? This is a nice study on monopolar TUR, which you can see it's fine if you look at 30 or less, and it's a little bit bigger if we consider bigger sizes with transfusion, TUR syndrome, which is not a problem with bipolar, and surgical revision. So this is what you need to counsel your patient if you have larger prostates. In the nice study from Sascha here, what are the meta-analysis, what are the complications on the long term? Bladder neck cirrhosis around 2, urethral strictures about 4, reintervention due to BPH 0.5, it's roughly 1%, 1.2% a year. So it is quite reasonable. So I like to quote Peter Gilling. He said, monopolar TUR is safe. The comparative studies between TURP, bipolar and monopolar are flawed because they have problems in the structure of it. And he says, and that is what I basically say, if it only was the elimination of the TUR syndrome, it's fine. And this is why I follow bipolar. It's the perfect tool for teaching. So what do the guidelines say? Sorry, this is what the guidelines say. Offer transurethral incision below 30 and offer bipolar as first choice at 30 to 80. So that is something to consider. So TURP is valid, TURP is a nice treatment, and TURP should be done. So the better is the enemy of good. So what could be TURP 2.0? And that could be TURP 2.0, published in 2010. This gentleman is Chunchal Liu. He put out this data, which was published as a 6-year follow-up, one single arm study. And he said fantastic results. If you look at that, there was no surgical redo for bipolar regrowth, and this is enucleation, resection, bipolar. So what about EEP, endoscopic enucleation? We'll hear more of that later also from Sascha. Could it be the future standard? And we look into here, so we have some current base as well in the 80 ml. So it's here first choice. So until 2015, it was only HOLEP, and then we reviewed the data of the bipolar, and from there on, because we saw it was equivalent to HOLEP with regard to big prostates, we call it EEP today. So, and this is the studies, 7 and 9 RCTs were studied, and they showed equivalence. We could have known this already since 2006, because there was a nice study from Peter Gilling and Neil, bipolar plasma kinetic enucleation with the HOLEP, and it was equivalent. However, we came from unique selling point projections to a conceptual understanding of enucleation, where energy source today is secondary. And therefore, I said enucleation is enucleation and so on, because anatomical enucleation is reproducible. So just some facts. This was 2 studies, 6-year follow-up, bipolar versus open prostatectomy. All parameters were there, including pressure flow studies, and you could see only operation time at that point, because that was old HOLEP studies and old bipolar studies without morcellators, was in favor of OP, and the pair of complications you can see were definitely in favor of bipolar. We have another nice study, 5 years follow-up, same design, and you see, of course, greater resected weight because it was an enucleation, bipolar enucleation, and shorter catheterization and hospitalization, and the urodynamic features were the same. Only after 3 years, this was split, and it was better in enucleation than TURP. I think to distinguish between TURP and open and enucleation, you really have to look beyond 3 years to see a difference, because then the retreatment or redo kicks in. So what about sexual? So the sexual function, which we saw on the last slide, is always a question. There is no de novo erectile dysfunction we see from enucleation, because this is a common feature about enucleation. We'll hear further on. And the antegrade ejaculation rate is around 50% if you do a ejaculatory hood preservation, which mainly covers the surrounding tissue of the verumontanum. So could bipolar enucleation be the standard for the future? We don't know, but it has a good potential. The point is that if you look at the cost for endoscopic enucleation of the prostate, you see there's a low capital investment cost, low cost of ownership, because you have hardly anything to buy. You can do TRP as with your standard equipment and standard skill set as enucleation resection, and you can add a morcellator, and if you wish so, you could even add a laser. And then sometimes questions kick in, do we really need lasers in transurethral enucleation or not? And this is probably the wrong question, because at the moment we just know that everything works with everything, and we don't know which energy source is superior. If we talk about RESUM, the question is RESUM a serious procedure when we compare it to TURP, or when we compare it to other treatments, surgical treatments? And again, the RESUM template is an extra anatomical template running in this regard, and you can see that it has a bandwidth where it comes around. So like TURP, like aquablation, like vaporization. So it's not a defined template. And just to kick in here, it's one of the novel treatments that have come, like PUL, the left above, then RESUM, like iTind and aquablation. And what they all try to deliver is high technology solutions they're all low-skill products, so you don't need a big skill set. And they most commonly are marketed for the secondary endpoint, ejaculation sparing or outpatient procedure. They, of course, deliver for shareholders because they all destinate from the stock markets. And the question is the socioeconomic cost perioperatively and on the long run because of retreatment. And the question is, will they stay or will they enter the guidelines as a treatment of choice, or will they vanish like many other treatments as well? And just that is something which I thought, if you look into the genealogy of reason, you could say it's a mixture between TUMT and tuna. And both, first of all, are no longer really in the market in Europe, except Scandinavia. TUMT, I think, is a big in Scandinavia still, and Rhizome is really getting momentum here. And we have to question, is it working or not? How does it work? So there is 0.42 ml water vapor injected into the prostate, which then moves until the boundaries of the transitional zone. And then we have condensation in between, interstitially, and we have a compensation, and then the energy is released. It generates the cell membranes, and we have tissue coagulation and necrosis. And this is all within 9 seconds with a simple injection. So this is how it should look like, as you can see here. So the vapor goes in, and at least the theory says that it stops at the peripheral zone. I'm not quite sure about that, but that's the model, and that is the theory of the effect. So what does it do? You can see here histology. There's a nice coagulation around the urethra, and what does it exactly do? We will see the lesions. They will resolve within 3 months, and then nearly completely resolve within 6 months. And it was tested in patients with small prostates. Now there is a big Rhizome XL study and the Rhizome 2 study. So the data from the single injection, this is what was marketed before, make a lesion around 1.7 centimeters square. So the total prostate volume in this study from Minders was reduced to 28% at 6 months, and the PSA level was unchanged at 3 and 6 months, which probably shows that there's still some inflammation going on in the prostate, which keeps the PSA up. This is the MRI, which I love very much. So you see the lesions are big in the beginning, and then they almost gone at 3 months. There's single injection on each lobe above and multiple below and in the median lobe. So that is what is happening. So the problem I see with Rhizome is not that it works. Of course it works. It's ablative. But we don't have comparative data to standard treatment like TURP. We have here, the longest study is about 4 years versus sham. And sham is not considered to be a good treatment for BPH. So we have a problem with the evidence so far, but what we can see in this study is the LUTs improved within less than 3 months. It is durable over the time of 4 years. There was no disturbances in sexual function, which it can be an argument, and it was seen as an alphas-based treatment and local anesthesia, and this is a real treatment, pro. But again, Rhizome is marketed for anticoagulatory patients at the moment, and this was non-study tested as a primarily inclusion criteria. So theory and effect, as you can see here, it works nicely up till 4 years. And of course, here the argument, the ejaculatory function is hardly changed. So NICE guidelines are not only nice by acronym, but also nice. And they say there's no evidence that directly compares Rhizome and the clinical experts. So do I consider Rhizome to be safe? It is too early for guideline recommendations. If the EAU, the AUA included it in the algorithm, although there's no treatment versus TURP LN. And of course, there's no best practice because it can be done by anyone. So it's not a really high skill set treatment. So if you are happy with 25% reduction, as you see with aquablation, you will probably be happy with Rhizome as well. And that's to finalize, at least Rhizome is one of the ablative solutions, and therefore it is valuable. But my major slide would be this. that anatomical inoculation is the new benchmark, be it laser or current. Thank you very much.
Thank you, Thomas. That was an excellent lecture delivered in classic Professor Herrmann style. Very good. So we got some questions here, Thomas, for you. Can we say, this is from Alessandro Estrada, can we say that the high incidence of re-TURP is due to incomplete resection performed by the surgeons?
I think if you do a limited TURP, I think you are much more likely to have a retreatment. But this is what you need to communicate before. So I think the Marberger data from Vienna are quite nice, and that was a retreatment 1.2 or 1% per year with TURP. If you do TURP with 50 years, then you will have a 20% chance when you are 70. So that is a reasonable chance. So of course, if you do limited TUR, we know this also from the first Relight data, you will have a higher recurrence of adenoma and a higher recurrence rate or high redo rate. So I think if you do a radical TURP, which traditionally is done in Central Europe, you will have some good or low redo rates. If you do a limited TUR or if you do a limited ablation, you will probably end up with a higher rate.
All right, that's fantastic. So a couple of more questions here. How long do the irritative symptoms last after resin?
So the data that is out is that almost everything resolves within 1 month. So that is also what I know from this treatment. It's like in TURP. I think if you have some patients where it will last longer and will have some more severe, I think dysuria I discovered a little bit more than what is written in these papers. But however, as you can see with the MRI study, after 3 months at least, it's almost gone, the effect is gone and the irritation is gone. So I would say dysuria is about 12%, 15%, and it is it's timely limited. And I would say after 1 month, everybody is sort of happy.
Okay, and this is a question perhaps for you and Sascha later from Raid Ghassan. Why doesn't the urology training program of fellowships introduce prostate artery embolization to be done by urologists rather than radiologists? I think that's a difficult question, Thomas.
That's a difficult question. So we put up prostate embolization at the MHH some 5 years back, and I always joined in the interventional radiology room, but I think you need really a certain skill set to do that. I think it's quite, and this is what is said in the guidelines, you cannot offer prostate arterial embolization as a radiologist if you are not trained for that, because I think the failure rate significantly correlates with whether you have been trained for that as well. So our initial series was even proctored in a new environment for the proctor was not so, let's say, overwhelming. And so there is an institutional learning curve and there is a surgeon's learning curve or interventional radiologist learning curve. So that must be considered. And I don't see a point in urologists doing that. We have good alternatives on the hand. And if you look into the NICE study of prostate embolization, it was 20% retreatment rate within the study, and at least 17% retrograde ejaculation rate. So it is not probably as we have seen from the other data.
So 2 rapid questions with short answers. I think they're both linked, one from Joseph and the other from Mohammed. What are the chances of recurrence after resin? You partly answered that in your lecture. And the second part from Mohammed is, what's the maximum size of the adenoma that you would consider treating with resin?
There is a there's a RESIM XL study out, and it tests 80 until 150 mLs with, I think, 6, 7 injections, I think Sascha has vast experience in rhizome. I think he should answer to that. I think there is not, so rhizome is something completely different. So rhizome is completely differently designed than TERP because it attracts patients either who are interested in ejaculation or want to have an outpatient treatment or cannot go under anesthesia. So that is where I see it. But I can believe that you can eject more in even larger glands, and you will see an effect, not a TERP-like effect or an enucleation-like effect, and you can redo this if it wasn't enough. But Sascha should talk about it. I think
okay, Sascha, we leave that to you. The last question, Thomas, very briefly. I think this is a good question because of laser and bipolar for enucleation. How long or steep is the enucleation curve? EEP, how long or steep do you think is the curve when you tell a trainee you're going to teach him? What would you advise?
Before I came to Switzerland, where I met a lot of good therapists, I thought it would be 25 to 50. If you are a good surgeon for TORP and good orientation anatomical wise, especially at the apex, it is about 15 to 20 cases. But if you are blank, I think you need about 25 to 50 cases to master the surgery. To become excellent, it is probably 100 and more. But I think to get a good idea to get through it from A to Z, and if you concentrate on prostates 40 to 50 ml and not larger, then you are through. If you are TERPist, within 15 to 20 cases, proctored. You shouldn't start it on your own.
Super. Thomas, fantastic. Thank you. We'll pass the floor on to Sascha now. I can't wait to hear Sascha's lecture as well. Fantastic, Thomas. So if you could pause. Thank you.
Me too.
Sascha, it's your turn. Yeah.
Thank you. So I just start straight away because it's a big topic. The topic is laser and less invasive treatment options. We had good discussions already. Hope to have more discussion following. First question is, do we need alternatives to monopolar TRP? Thomas has partially answered this question. He also showed this slide. It's a prospective study from Germany who really showed that there is substantial morbidity in TRP, especially if we are facing larger prostates, which is our clinical practice now and in the future. People come at an older age, mostly due to medication, and present with larger prostates. So we need alternatives, and alternatives, of course, could be or are lasers. What is laser? It's an acronym and stands for light amplification by stimulated emission of radiation. The ground principle was discovered by none less than Albert Einstein. He founded the ground principle. In general, we can say that laser light generates heat. However, lasers differ between each other. Each laser has a specific wavelength, and according to the wavelengths, you have different penetration depth into the tissue. Here are the current lasers in use in urology: the green light laser, diode laser, holmium, and thorium laser. We can see that penetration depth into the prostatic tissue is very shallow in the holmium laser and the thorium laser, and become deeper in the green light and diode laser. The evolution of laser in general was that people started to vaporize. Then they found, most of the time, they found out that it takes a little bit long. Then they started to resect, and now finally they ended up to enucleate. Just from the nomenclature, you can see that you can use every laser for everything, but it's evident according to the wavelength that there must be some benefit for the one and the other lasers. Let's start with the holmium laser. I will not go too much into detail. I start straight away a little bit with the video to show his interaction with prostatic tissue. Here is the start of an enucleation of the prostate, the whole lab, apically left lobe, and you can see that it is an end-fire laser which is mostly used in a non-contact technique in general, to coagulate the radial vessels who come from the surgical capsule. And the tissue is more or less pushed off by the laser itself, and a little bit by a little mechanical push of the laser resectoscope, but mainly it's coagulation. Okay, let's proceed. What about the body of evidence? We have more than 20 years of history of HOLEP, and just due to the publication, we can really state that HOLEP is the most widely scrutinized surgical technique for LUTS and BPH nowadays. These are the randomized controlled trials, and they all come to the same result, that is, has a lower intra and perioperative morbidity when compared to TURP and open prostatectomy. It has a shorter catheter time and length of hospital stay. Late complications are rare, and it is, that's very important, completely size independent. It is the first procedure who has shown in meta-analysis a superior efficacy when compared to TURP. And what is also an important fact, specifically for me, but in general, of course, is that it is a Swiss Army knife. I cannot imagine working in a hospital without a Thorium laser, because you need it anyhow for stone treatment. You can use it for tumor ablation, for urethrotomy, and of course for the treatment of the prostate in terms of an enucleation. What do the EAU guidelines say? The recommendations are very strong to use it as a first-line alternative in patients instead of TURP or open prostatectomy. Let's come to the green light laser. Again, showing a short video demonstrating how it is usually used in a side firing technique, totally different to the Thorium laser, which is an end firing technique. The tissue is vaporized, and it is used in a side fire with a side fire fiber, which is a single-use fiber, which is expensive in use. And it is absorbed, the laser energy, instead of water as it is in the Thorium laser, the laser energy is absorbed by the hemoglobin, which makes it very hemostatic, and probably this is exactly where its main application should take place in patients who are at risk of bleeding, in anticoagulated patients. What does the evidence show? These are all the randomized controlled trials we have, comparing different powers from 180 to 120 of green light laser compared to TURP. Again, all randomized controlled trials come to very similar results, that the green light laser has a lower intraoperative morbidity. It seems equally effective as TURP in the short to midterm in small to moderate sized prostates. It is not wise so far, there's no evidence to use it in larger prostates, in prostates larger than 80 milliliters. So this is also reflected in the current guidelines 2020. The recommendation is strong, no matter what power of laser you have in a green light laser, to use it as a first-line alternative to TURP, not to open prostatectomy. What about the Thorium laser? Again, let's watch at the video to become more plastic within the talk. It can be used in an enucleation technique. It can be used as a resection technique. Actually, most data what we have are from, or let's say most level 1 data what we have are using the laser, the Thorium laser, as a Thorium laser resection of the prostate. However, in today's clinical practice, most people use it probably for enucleation in terms of a THULEP if it's very anatomical, or in terms of a THU-VEP if it's rather less anatomical. As you can see here in comparison maybe to the Thorium laser, there's a little bit of charring, and this might make it a little bit more difficult to identify the surgical capsule. So this is the body of evidence. Most randomized controlled trials are comparing Thorium vaporesection of the prostate with TRP, also bipolar TRP, and there's one randomized control trial comparing it with THULEP versus TRP. There is a need of more randomized controlled studies, specifically if we look at the recommendations within the guidelines, the current guidelines. There's only weak recommendation of THULEP and THUVEP, although it is clinically people use thulium laser and not doing probably wrong with it for enucleation. Most strongest recommendation is using the thulium laser in terms of a thulium vaporesection of the prostate. What about the diode laser? Again, a short video clip demonstrating actually visually its deeper penetration within the tissue, which can be seen here. It penetrates deeper. For this reason, there are some studies who reported some severe side effects. However, there's one randomized control trial comparing it to TRP and one to plasma kinetic enucleation. However, in general, the recommendations are rather weak in using it as an alternative to TRP or to in an enucleation technique. Where are we heading? Thomas already stressed this topic. We are heading definitely towards endoscopic enucleation. Most evidence is probably for lasers. However, if you enucleate transurethral endoscopically, you have a maximal tissue ablation. For this reason, you have probably better results than in TURP. It's size independent, it has good long-term outcome, and you have a complete histology in most of the cases. This is also shown within the guideline algorithm. The green light laser is now also sometimes, or from some people, used to enucleate. It's called GreenLab. However, its pioneer, Gomez Sanchez, stated at the last EAU that he moved on from GreenLab to HoLab because it's probably more difficult. Let's come to less invasive procedure. There's the mechanical device like prostatic urethral lift. Here in this pictures, images, you can see how it is applied. There is evidence, you can do it in local anesthesia, and there's evidence that it has lasting effect in a sham control randomized trial until 5 years, of course, with almost 15 to around 15% of retreatment. But the most important message, the sexual function remains stable. Alternatively, there might be another device like the TINT, but there needs to be more data for this specific procedure. So if we look at the EAU guidelines, offer prostatic urethral lift to men who are interested in preserving their ejaculatory function in prostates which are smaller than 70, and very important, which might be an advantage for RESUM. Don't use it in patients with don't use Urolift in patients with a middle lobe, and RESUM you could, for example, use in patients with a middle lobe. Let's come to aqua ablation, another very interesting procedure who was very much discussed at the last EAU. It is a water stream is used to ablate the prostate. The boundaries are set by sonography. It's real-time sonography, and most part of the prostate, rather the lateral and dorsal part of the prostate, is ablated according to the ultrasound boundaries, as it is a force which can even be used to cut, let's say, iron. There is no hemostasis really. So the inventors of this procedure, they are looking for more hemostasis within these procedures. The first study was the water study. It demonstrated that it is similarly effective as TRP, but the safety is not superior to TRP. There are even more bleeding risks. The major advantage compared to TRP in this study was specifically that there was less an ejaculation in the aqua ablation arm. You can also use it in larger prostate, this is shown in the Water 2 study, where larger prostates are tackled. The procedure itself, it's very fast. It just needs a little, some few minutes. But the issue is the hemostasis. So if you look at the EAU guidelines, we can see that it is recommended, weak recommendation, 30 to 80 milliliters, and importantly, inform patients about the risk of bleeding and the lack of long-term data, strong evidence. Finally, what about prostatic artery embolization? It has been discovered already in '79, and the body of evidence we have right now is not too bad. We have 3 randomized controlled trials, we have 2 meta-analyses, and let's look at the results of the last meta-analysis. It shows that the PA, prostatic artery embolization, is not as effective as established surgeries, but has probably less side effects. It might, but also have some severe side effects. It cannot yet be considered the standard treatment. And if you look at the procedure, it can be performed in local anesthesia. It's specifically well for patients maybe who have bleeding risk, but the radiation dose is also high. So looking at the results of the registry study, it says that especially what we were discussing about, you need a very experienced interventional radiologist, and the results lie between, let's say, drugs and real surgery. So there's weak recommendation and there's strong recommendation that you need a good interventional radiologist. One gold standard is probably history. One size does not fit all. And we have a shift of paradigm towards individualized therapy. Thank you.
Thank you, Sascha. There's a couple of questions from the floor. So the first I would like to ask from Osama Shaheen. He says, is it reasonable to use cystostomy in enucleation technique to avoid high pressure in the bladder? What's your thought on that, Sascha?
That's a very good question. If people come with the cystostomy or a suprapubic catheter, I even close the suprapubic catheter when I perform HoLEP in my hands. We close the suprapubic catheter or the cystostomy because you want to have the bladder distended, not only at the end of the surgery, already during the surgery. Otherwise, the prostate itself collapses too much and no cystostomy.
So you use a continuous flow sheath, is it?
Exactly, and there's no data of real TUR syndrome in laser or in laser enucleation. Of course, there is minimal TUR syndrome, not syndrome, but there's a little bit of influx, but not clinical relevant.
Thank you. There is another question from Joseph Philipprai. He says, he asked, how perfectly can you control the extent of ablation in aquablation?
I think the extent can be controlled quite well due to sonography. It can be repeated also within one session, specifically in larger glands. I think the control is quite well, except for the apical region. This, in my consideration, can be difficult, and it can also lead to some severe side effect. If you go closer into the publication, there seems to be the possibility even to sphincter injury. So you have to take very much care of the boundaries.
Yeah. So my personal commentator with Torsten Bach, who is also doing a lot, says he enlarged the template which he is ablating because he has a PSA drop of more than 50%. And he told me that he's doing for hemostasis TURP, not TURP, but coagulation at the end of the treatment to come down with the side effects that Water 2 showed. Is it what you are doing also after aquablation? If you do aquablation, do you go in and coagulate, or you leave it like that and contraction?
We haven't started with aquablation yet.
Okay, sorry.
But we will probably, what I thought, I went and observed aquablation. I would consider it as a hybrid procedure where you should probably go for secondary coagulation within the procedure or at the end of the procedure. Yes.
There is another question from Joseph Philip Prach. Do the patients after PAE, prostatic embolization, have symptoms like post-embolization in RCC?
Yes, they probably have. Yes, some patients have post-interventional symptoms, and it takes a little bit of time to get relieved.
So we regularly used to apply a little bit of prednisone and some painkillers. So that is what I can tell from that, my limited, humble experience with that. And there was another question regarding the suprapubic catheter by Alim Dimov. And he asked, do you put in the suprapubic catheter anyway, or is it done with that?
I never put
for example, other conditions where you do it. For example, he asked for patients with large prostate, large bladder, residual volume, and hypocontractile diffuser.
Very, very good questions. At the beginning, I always put a catheter, a suprapubic catheter in patients who had more than 300 milliliter residuals because they are at higher risk of post-urinary of urinary retention. But there's a paper out who showed that after HoLEP, there's more than 90%, even in underactive bladder, who are able to urinate. So I stopped doing it, and so I never put it anymore because actually most people are able to urinate after HoLEP or after endoscopic enucleation.
Thank you very much. That was a question from the floor. I give back to Vijay.
Thank you. I have a question for both of you. Just a very, very brief answer, Thomas. I give you a choice between bipolar or HoLEP for enucleation. Which one will you choose?
If it's an anticoagulated patient, I use bipolar, and if not, I use laser.
What about you, Sascha? I know you'll use HoLEP.
Yeah, I use HoLEP, and yeah, I'm fine with it. I'm very fine with it.
Super. So what remains is for me to thank the ESU, the organizers, the fantastic organizers of this webinar. I thought it was an excellent webinar. My gratitude really to both Thomas and Sascha. To get two world experts together in this webinar is not easy. So I thank you for your time, and also thank you to the large number of attendees that we've had to make this a very successful and compact webinar. Thank you very much, and goodbye.
Thank you. Bye-bye.
Thank you.
Bye-bye. Thank you for your attendance.
Thank you.